Well, welcome everyone. Hopefully more people will join as I'm saying my little blah, 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 which is the least important part. Welcome everyone. I'm Maria Marshall. I'm the director of the North Central Regional Center for Rural Development. Welcome to our webinar series, it's October, our October webinar. And Liz, if you can put up the first slide. Just a reminder that our webinar is recorded and you should get an email link to the recording later. So again, welcome to our webinar, Healthcare Access Among Self-Employed Workers in Non-Metropolitan Counties. Our speakers will be Liz Dobis and Jessica Todd, and I'll introduce them in a second. But first, I'll remind you of our November webinar. Go to the next slide, Liz. The next webinar will be on supporting rural grocery across the grocery stores across the North Central region. That should be a really interesting seminar of just different perspectives on this issue. So November 7th at 2 p.m. We look forward to seeing you all there. So our guest speakers today for our presentations are Dr. Elizabeth Dobis, who is a research agricultural economist in the rural economy branch of the Resource and Rural Economic Division. She conducts research on rural health, and her recent work has focused on healthcare access, mid-age mortality, life expectancy, and the COVID-19 pandemic. She's a member of the Southern Regional Science Association's Executive Council and serves as the ERS liaison to the NCRCRD Board of Directors. So we can call upon her to do webinars like this. She will be speaking with Dr. Jessica Todd, who's an agriculture economist in the Food Economics Division, Food Assistance Branch of the USDA's Economic Research Service. She conducts research on the Special Supplemental Nutrition Program for women, infants, and children, and child nutrition programs. At ERS, Dr. Todd has also held positions studying farm households in the Resource and Rural Economics Division, Farm Economy Branch, and the economics of food choice, diet and health outcomes, and food and nutrition assistance programs in FED's Diet, Safety, and Health Economics Branch. So welcome, Liz and Jessica, and we look forward to hearing what you have to say.
Thanks, Maria. So like Maria said, my name is Elizabeth Dobis. I am going to present today on some work I did with Jessica, my co-author, on healthcare access among self-employed workers in non-metropolitan counties. And so I just wanted to start this webinar out by talking a little bit about why we care about healthcare access. And really what it is that greater access to healthcare is meant to improve the overall health and quality of life of individuals, and then therefore the general population. So it's actually a really important topic for us to look into and to study. But the first thing we're going to ask when we are looking at healthcare access is what affects healthcare access. So when thinking about this, Jessica and I felt that there were three main factors that are affecting access to healthcare. The first of those factors is the availability of healthcare resource. So what we mean by this is, what is the physical infrastructure of the healthcare system? This is things like the location of facilities and providers, the services available, whether they're a little bit more general or if they're more specialized, as well as the ability to reach care in a timely manner. The second factor that affects healthcare access is affordability of medical services. And this is really about whether people can pay for their preventative, elective, and emergency medical care, and if they can, whether those costs are a burden. And then finally, there's this idea of willingness to receive medical care. Now, not everybody really wants to receive medical care. They may distrust medical providers, or there could be societal opinions like stigma that's sometimes associated with medical care, like mental health issues, that may dissuade people from getting that care that they need. So they may be unwilling to actually receive medical care. Also in this particular report, you've noticed that we're focusing on self-employed workers as well as non-metropolitan counties. So I want to share a little bit about what we mean by self-employed workers. So self-employed workers are individuals who work for themselves in an unincorporated business rather than for a private company, a government, or as an unpaid family worker. They comprise 4.1% of US adults aged 26 and older, and 6.8% of households in the United States had at least one self-employed member. However, self-employed workers often do not have direct access to employer-based group health insurance plans, and so they can get their coverage through alternate means. Some options include purchasing directly through an insurance company or the health insurance marketplace, obtaining their insurance through a publicly subsidized insurance plan, or sometimes they also will get insurance through a family member's employer-based plan. Now, as far as non-metro counties go, they're a little bit unique as well. They have smaller populations, which can limit choice due to fewer facilities and less specialized medical services, while longer travel distances may increase the difficulty of accessing care. They also have a larger share of self-employed workers in their workforce. So 17.4% of workers in non-metro counties are self-employed versus 13.5% for the US as a whole. So taking this into account, what's our motivation for actually studying self-employed workers in non-metro counties? Well, because healthcare access factors that we discussed are influenced by both personal characteristics, such as your type of employment, your age, and your income, as well as locational characteristics, such as the resources available in your community or the medical services at the facilities nearby, self-employed workers in non-metropolitan areas definitely experience a unique blend of factors that are affecting both the availability and the affordability of their medical services. And so it's really important to understand what's going on with that particular population. So this report, just briefly, is going to describe healthcare costs, insurance coverage, and the numbers of professionals and facilities between 2014 and 2018, while the Affordable Care Act, also known as the ACA or Obamacare, was in full effect. And the conditions influencing the availability and the affordability since this data was collected have changed a little bit, right? So in 2019, the repeal of the individual mandate, which required people to have health insurance or pay a fine, that repeal went into effect in 2019. And also, I'm sure it was on everybody's mind, COVID has affected healthcare access and the way that people use healthcare, and that started in 2020. So there have definitely been changes since this data was collected. So with all this in mind, we have three main sections to this report. In the first section, we look at the affordability of healthcare. This focuses on the affordability for individuals and households. The second section looks at the availability of healthcare, and this is a more location-based, so we're looking at counties in this particular analysis. And the final section of the report looks at changes in affordability and availability during 2020, and this focuses more on individuals. So with that in mind, I'll dive into the nitty-gritty of what's going on in this report. So first, we want to talk about the affordability of healthcare resources. Now, one thing to keep in mind when we talk about affordability is that while being insured does not guarantee that healthcare services will be affordable, it can reduce the costs for many services. This particular section is going to use data from the annual social and economic supplement of the 2019 current population survey. So we'll jump right into this. It's kind of a busy chart as I was looking at it and trying to explain it. But this particular figure looks at health insurance coverage of adults aged 26 and older by age, worker classification, metropolitan status, and the source of coverage in 2018. So the chart on the left is looking at shares in different groups for working age adults, and the chart on the right is focusing more on retirement age adults. So focusing in on our working age adult chart on the left, I'll describe what we're seeing here. So this chart is divided into four main groups by worker classification. We have our group of self-employed workers, We have what we're calling other employed workers here, which is workers who are employed by private industry or the government. We have a section for people who are unemployed, so they're looking for a job, but they don't have one currently. And then we have our group for not in the labor force. This is people who are retired, who may be students, but don't have a part-time job, people who are working from, like, who are stay-at-home moms, and people who are in the armed forces, just to name a few. So each of these groups, we've divided then into people living in non-metropolitan counties and people living in metropolitan counties. And within each group, so let's say self-employed non-metropolitan, we're looking at the share of those individuals who are covered by different types of insurance. So we've got 4 different categories of insurance types. The first one is you don't have any insurance, you're uninsured. That's represented on these charts by the darker blue. The second one is employer-based group health insurance plans, and that's represented by the lighter blue on the charts. We've got direct purchase insurance, which is represented by the dark green. And then we have plans that are publicly subsidized, or public insurance plans, which are represented by the light. So our working age adults are individuals who are ages 26 to 64. But overall, looking at both of these charts, we see that there are different patterns of health insurance coverage by worker classification. But in general, there are similar patterns and shares in metro and non-metro counties. So if we focus in the non-metro and metro for the self-employed, they look pretty similar. Same for each group that we're looking at here. So focusing in on our working age adults in the chart on the left, I'll start with the uninsured. What we can see here is that self-employed working age adults were more likely to be uninsured than those employed by government or other employers, right? So we see a pretty high dark blue line there. The next thing of note that you may not expect is that the highest source of health insurance coverage for these self-employed individuals is group health insurance or employer-based health insurance. And this is actually probably because they're covered by another household member's employer-based plan. Because when we look at households that have both self-employed individuals and individuals who have a job, based out of the government or private employers, we find that 58.5% of those self-employed individuals who are dependents are dependent on another household member's plan. So there's quite a bit of the numbers are suggesting that this is probably related to another household member's plan. A couple of other things to notice when you're comparing the self-employed individuals and the other employed individuals is that the self-employed have the highest rate of direct purchase insurance, and they also have a rate of public insurance that's twice that of those working in government or private industry. So now that's kind of what we're seeing in the working age adults, right? It's a very different pattern for the self-employed and other employed individuals. But when you look at the working age adults, the chart looks very different than what you were seeing for retirement age adults, right? And this is the reason that we split them up, is that when you hit age 65, you're eligible for Medicare. And so that's going to really affect your insurance choices, and really it's going to affect the rate of insurance in the population. So as you can see by those really tall light green lines, the retirement age adults, including those that are self-employed, are much more likely to be covered by public insurance plans than any other source of health insurance. But if you're looking at this, a lot of these are, between the high 70s and the high 90s in terms of rates. So when you're thinking, okay, let's add these all together, you add all the bars together, it's more than 100%. Well, this is because retirement age adults are more likely to have multiple sources of health insurance coverage. So for working age adults, only 5.4% have multiple insurance plans, whereas 55.4% of retirement age adults have those multiple insurance plans. And, as is suggested by these bars, retirement age adults are also are less likely to be uninsured than working age adults. So thinking about this as a whole, these results are really suggesting that only looking at health insurance coverage for individuals doesn't really accurately portray the decisions that people are making. And so many households make employment and health insurance decisions as a unit. So it's better to look at households as a whole, households and individuals, to really understand the choices that are being made for individuals. So this next chart is very similar to the previous chart. It's got the same types of insurance coverage. It's got the non-metro and metro distinction, but it's for households. So it's showing the health insurance coverage in households with self-employed members by member age, worker classification, source of insurance, and metropolitan status in 2018. Now, the big difference between these charts for households and the ones for individuals is how do we represent the worker classification, right? So we've divided households into households where all adults age 26 and older are self-employed, households where you've got a mix of self-employed adults and people who adults that work for the government and private firms. And then you've got the households where everybody works for government or private firms. So those are the only employed, the other employed only households, right? So we've got the self-employed, the mixed employment, and the other employed. And that's trying to give us an idea of, okay, what are we seeing with the different insurance types based on the mix of worker classification that we're seeing. And basically what you find is that household level health insurance varied more by these different types of employment than by metropolitan status. So in chart A, so chart A is the one on the left where we're looking at only household with working age adults. There are no people age 65 in these households, 65 and older in these households. What you can see is that for self-employed only households, health insurance coverage is pretty evenly spread, or more evenly spread among the different types of insurance coverage, uninsured, direct purchase, employer-based, as well as public insurance. And what you're finding is that in these households, the public insurance and the direct purchase insurance is much higher than in the other two types of households, right? But we're also seeing that uninsurance was also much higher in these. It was 22% in non-metro areas and 18.1% in metro areas. And this basically, when you're looking at this, what we're finding is that having at least one additional one member of the household being employed by by government or by a private firm, having at least one other employed individual in a household makes that household nearly 3 times less likely to be completely uninsured than one where all workers are self-employed, right? So pretty important statistic. Again, comparing the households that are only working age on the left with the households that have at least one retirement age adult on the right, we can again see the effects of Medicare in the chart, in that over 95% of these households had public health insurance plans. However, there's just a much larger proportion of these households that are other employed or mixed employment that have the direct purchase plans than you would see in the households that are just working age adults in them. So that kind of gives us an idea of what's going on with the insurance. We're really just seeing that the insurance, the type of insurance is more dependent or more related to the type of employment that workers have, whether they're self-employed versus not self-employed, rather than whether they live in a metropolitan or a non-metropolitan area. But this is only telling us part of the story. So now we're going to move on to looking at how insurance coverage affects medical expenditures. So this chart shows the mean medical expenditures per family member for families in non-metropolitan counties by member age and source of health insurance coverage. Now, because the amounts, the rates and patterns for metro and non-metro counties were very similar with differences less than $100, I chose just to show you the non-metropolitan figures because they should illustrate the patterns that we're seeing and give you what's going on in that area as well. So here I've got the different categories, all families, the families with just working age adults, and then the families with retirement age adults in them as well. And we're looking at it for all insurance sources and then by type of insurance source, right? So the first thing to notice is on average, the breakdown per person in a family is you generally, on average, they'll spend $2,130 on medical expenses throughout the year. Now, about half of this, $1,144 on average, goes to out-of-pocket health insurance premiums. The other half is split between out-of-pocket healthcare spending, which is $815 on average, and over-the-counter expenditures, which is $171 on average. Now, what we're finding, though, is that when you start breaking this down by type of insurance, so comparing employer-based direct purchase insurance and public insurance, what we're finding is that the biggest difference in expenditures is due to the premiums by the source of insurance coverage. So direct purchase insurance has the highest premiums, with on average $1,832 per person per year for direct purchase insurance premiums out of pocket. This is compared with the out-of-pocket insurance premiums for employer-based, which are about $350 lower at $1,496. And then the lowest is public insurance with annual premiums of approximately $793 per person. So this is really what's we're seeing as driving the differences in total medical expenses. Now, we also want to take into account what's going on when we compare ages. So retirement age families pay slightly more in total medical expenses than working age families. They pay about $2,324 on average per person versus working age families, which is about $2,016 per year on average. And this difference is actually mainly due to out-of-pocket and over-the-counter expenses rather than premiums. And we believe this is probably associated with greater use of medical resources among older adults. So now that we've talked a lot about health insurance coverage, medical expenses, and the affordability of healthcare, we're going to move on to the second section of this particular report, which is the availability of healthcare resources. So while the availability of healthcare services does not mean that they're necessarily going to be affordable, reduced availability may prevent patients from receiving timely medical care. So availability is also very important. As I mentioned, this is a county level analysis, and it's using data from the Area Health Resource File and the American Community Survey to try and analyze what's going on in different locations throughout the country. So here we're going to start. One thing I did want to mention is what we're looking at here is that the availability of healthcare facilities is varying across U.S. regions and rurality, and that's what's shown in this chart. But if you think about it, healthcare facilities and providers are not evenly spread throughout the country, and that even within groups such as regions or metropolitan, micropolitan classifications, you're still going to see some differences amongst the counties in those groups. And this is because not every county needs or has the population to support, different types of medical facilities, such as a hospital or a skilled nursing facility. And not all hospitals employ physicians for every specialty, which is going to further disperse the medical services that are available to patients. And so these factors together are going to lead to variations in healthcare facilities, even within these metropolitan classifications. And these geographic variations can eventually affect the access to medical care, the amount of distance that people need to travel to medical care. So maybe even if there's somebody in your town, you've got your primary care physician in your town, if you need some sort of specialized care, let's say you tripped and you need to go see an orthopedic surgeon to evaluate your mobility, you may have to drive quite a while to visit that orthopedic surgeon if there isn't one nearby. So this can really affect the way that you access care. So this table is showing the percentage of US counties with medical facilities by region and by metropolitan status. So we're looking at hospitals, short-term general, so this is all hospitals. Short-term general hospitals, that's generally what you think about when you go to the ER or hospital like that. And then skilled nursing facilities. We look at this by metropolitan, micropolitan, and non-core. So micropolitan counties are counties that are basically non-metropolitan population hubs, or counties that are connected to those. And then non-core counties are basically all other counties, because of the way that the census defines things. If it's most rural, it's everything else, right? And then we also looked at this by the major regions: Midwest, Northeast, South, and West. So what we find here is that a smaller share of non-core counties had medical facilities, that the greatest shares for hospitals were in micropolitan counties, while for skilled nursing facilities, the greatest shares were in metropolitan counties. And that overall, the Northeast had the best access to medical facilities, and as you'll see later, and providers, which is not actually here. Check out the report if you want more detail, because there's a lot more detail in this report. I'm just trying to give you the really distilled information. So if you want more details, check out the report. But we also see that the South had the worst access to medical facilities and providers. However, the amount of medical resources available at these facilities is also really important to understand the availability of healthcare. So that leads us to our next chart. This chart is looking at the healthcare availability measures, that basically measures of healthcare availability by metropolitan status. In this chart, we have information on the average bed to population ratio. So this is the number of beds per 10,000 residents. The average provider to population ratio. So this is different types of providers. Here we've got total physicians, primary care physicians, and dentists. And then we've got the share of counties that are completely covered by a healthcare professional, like a health professional shortage area. Now, these are areas that are defined by the Department of Health and Human Services that meet certain requirements. And so counties can have certain parts of the county that are covered, that have this shortage area, no parts of the counties that have this shortage area, or the entire county has at least one shortage area covering it. So these are counties where the entire county is a shortage area. All right, so what do we find? Overall, we're finding that the availability of healthcare resources varied by county rurality. So metropolitan and micropolitan and non-core counties have very different types of levels of availability. We're finding that metropolitan counties had the greatest availability of medical professionals, but the fewest beds per 10,000 residents. Non-core counties, we're seeing that they have the largest number of beds per 10,000 residents, but the fewest healthcare professionals. And they are also the most likely to be completely covered, to be completely part of these health professional shortage areas. I also thought it was interesting to look at the share of counties with the different types of health professional shortages. So when you compare the primary care, dentist, and mental health professional shortage areas, what we see is there are the fewest shortage areas for dentists. Primary care is in the middle, and perhaps unexpectedly, there are more mental health professional shortage areas than any other type. When you look at the share of counties that are completely covered by these health professional shortage areas. In fact, interestingly enough, in non-core counties, I find this number to be really crazy. 80% of these non-core counties are completely covered, and 70% of the micro counties. And that's compared to 36% in metro counties. But that's even quite a bit more than what you're seeing for the healthcare, the primary care even. So not unexpected, but pretty impressive, and maybe not a good way. So far in this section, you may have noticed we were focusing primarily on metro versus micro versus non-core, on how urban or how rural counties are. But this report is more about self-employed workers in non-metro counties. So how do we bring this in? We're introducing self-employment to this analysis through the share of workers in a county that are self-employed. So this map shows high self-employment counties in the United States by metropolitan status from 2014 to 2018. In this map, the dark red counties are non-metropolitan high self-employment counties, and the pink counties are metropolitan high self-employment counties. The white counties are not considered to have high self-employment. So what do we mean by high self-employment? Well, high self-employment counties are in the highest quartile by the share of workers who are self-employed. So if we look at the highest, rank out all the counties by self-employment, the share of workers who are self-employed, if we're taking the top 25% in terms of the share who are self-employed, those are our high self-employment counties. And so those counties, between 9.1% and 36.7% of workers are self-employed. This is, there are 786 of these counties, and they're spread across 84 metro and 702 non-metro counties. And what you can really see here by the grouping and the clustering in this map is that they're quite concentrated in the Great Plains and the Upper Mountain West. So this classification allows us to analyze the availability of healthcare services, which we discussed in the previous slide. And when we look at that, we actually see some interesting patterns emerge in terms of the availability of doctors by the share of self-employed workers in the county. So this particular figure is showing us the mean rate of medical doctors, or MDs, per 10,000 residents in US counties by self-employment quartile and metropolitan status. So we've split the counties up into 3 groups. So those groups are represented by different colors. So the high self-employment counties are represented by the dark blue. Those are the people with in the top 25% of self-employment for the workers. Then we have the middle 50%, which are represented by the light blue, and the lower 25% are the people with the lowest amount of self-employment. Those are represented by the green. The other difference that you're seeing here is metro versus non-metro. So the lines that you're seeing here that are dashed represent the metropolitan values, whereas the solid lines are the non-metropolitan values. So what we can see in this chart is that between 1970 and 2000, the average rate of MDs increased for all county types, right? So there was an increase. But then in 2000, we see some changes in the trends. We see that after 2000, the average rate of doctors started decreasing in non-metro counties, while the increases in metropolitan counties slowed, right? So we get a change in the slope. So by 2017, which is the last year we were able to include here, the average rate of doctors in low self-employment non-metropolitan counties fell below the rate in high self-employment metro counties. So basically what we're saying is that in 2017, the rate of doctors in all types of metropolitan counties was higher than the rate of doctors in all types of non-metropolitan counties. And we're also seeing a divergence, right? So we're seeing an increase at the very top and a decrease at the very bottom, so that the gap between the high self-employment metro counties, that's up here, somewhere between 20 and 25% up here, had increased to 16, basically they had 16 more doctors per 10,000 residents than the very lowest category, which is the high self-employment non-metropolitan counties down here. And so this leads us to conclude that the availability of medical doctors favors metro counties with low rates of self-employment. And this is emphasized by the fact that in 2019, counties with a high share of self-employed workers were more likely to be identified as having a health professional shortage area than other counties. So one thing that I find pretty interesting, though, is that despite this disparity, this doesn't necessarily mean that there's a sufficient supply of doctors in metropolitan areas. They have more of them, but that doesn't necessarily mean that there are enough to provide adequate care for everybody. And in fact, in 2017, the mean numbers of total physicians and primary care physicians per capita in the US were below the rates projected as necessary to provide adequate medical care based on the population characteristics of the nation in 2000. So based on some work that was done by the Department of Health and Human Services using the 2000 census data, they were saying, well, you know, these rates are below what we would need to really provide adequate medical care for everybody in the nation. So just because they have more doesn't mean they have enough. All right, so that gives us an idea of what's going on with affordability and availability. But we all know that COVID-19 was a big shock to the healthcare system and the economy. We had the mandatory shutdowns of businesses. A lot of people lost their jobs, or even if they didn't lose their jobs, they experienced a loss of income. And that may have affected the patterns that we were seeing in terms of affordability pre-pandemic. Additionally, we might be seeing differences in availability because there were alterations in the way that hospitals were treating patients, and with preventing, with prioritizing COVID patients and not doing any elective surgeries for a while. It can really alter the way that people are able to access care in terms of availability. So we wanted to take a look at what was going on during 2020 and see what kind of changes we were seeing during 2020. Now, we were using this novel survey, the 2020 Household Pulse Survey that was conducted by the Census Bureau. It's an individual level survey, and it's actually ongoing, but we only used phases 1, 2, and part of phase 3 through the end of 2020. So this figure shows two types of insurance coverage. So uninsured individuals on the left, and people who are insured by employer-based group plans on the right. And it's showing the coverage through for those who worked in the past week by metropolitan and self-employment status from April 23rd to December 21st, 2020. So similar to the last line chart that I showed you, we're splitting this into metro and non-metro, where the dashed lines represent the metropolitan values and the solid lines represent the non-metropolitan values. We also have the self-employed individuals represented by the dark blue, and the workers that are not self-employed are represented by the light blue. So Similar to the patterns that we saw in 2018, we are seeing that a higher number of self-employed individuals are uninsured than people who are employed through other means. However, these values here at the beginning are higher than what we saw in terms of uninsured rates of uninsured individuals in 2018. So we started out with slightly higher rates, but the main pattern in terms of compared between the self-employed and the not self-employed remained the same. Over the course of the pandemic in 2020, we did see an increase in the rate of people who were uninsured. And then, as you might expect, at the same time, we're also seeing a decrease in the people who had insurance through the employer-based health insurance plans. However, insurance coverage was not the only aspect of healthcare access that was affected by the pandemic. So COVID-19 impacted medical service use and overall population health in 2020. So over the course of the pandemic, the share of respondents to this household pulse survey that delayed getting medical care or did not get needed medical care decreased. So, availability increased and willingness to receive care increased over time. However, what we're seeing is that at the beginning, about 40% of people delayed medical care, and then 31 to 33% didn't get needed medical care. So we are seeing an improvement from those numbers, but the pandemic was definitely impacting the availability and the willingness to access medical care. Another thing that I thought was kind of interesting is that metropolitan residents were more likely to report excellent or very good health than non-metropolitan area residents. So people in metro areas felt that they were healthier than people in non-metro areas. But in those non-metro areas, there was a difference between people who were self-employed and people who were employed through government or private companies. So self-employed workers, 64.6% of them were reported that they had excellent or very good health, compared to only 57.9% for other employed workers. But throughout the pandemic, we saw declines in health for everybody. But most of that decline happened at the beginning of the pandemic. All right. So that's the end of that final section of the report, of analysis in this report. And so we've touched on quite a few topics over the course of this webinar. And so I'd like to end with a few takeaways. Okay. As far as the motivation for this report goes, the key takeaways are greater healthcare access is meant to improve the overall health of US residents along with their quality of life. Access is affected by a combination of personal and location characteristics. And from a community development standpoint, this means that you need to be aware of the factors associated with how residents access healthcare, right? And then we also find that self-employed workers in non-metro areas experience a unique blend of factors that are affecting the availability of medical services, mainly related to their location, as well as the affordability of medical services, which is more related to their personal characteristics. As far as the first of the factors affecting healthcare access goes, affordability, the big takeaways from this particular report are that health insurance coverage rates and sources differed more by age and whether workers are self-employed than by metropolitan status. We also found that households play a big role in the source of health insurance coverage that the self-employed workers have, if they have any. Age is another big factor because retirement age adults and households experienced different health insurance coverage patterns than those who are working age. Additionally, family medical expenditures differed more by age and source of insurance coverage than by metropolitan status or whether a member is self-employed. And this is primarily due to the premiums and the use of medical services that these different groups have. Focusing then on availability and what's been happening since 2018 in terms of availability of healthcare facilities and providers, we're seeing that they vary across US regions and by rurality, and that accessing medical care may have been more difficult in non-core and high self-employment counties due to fewer medical facilities and lower rates of medical professionals. And the one thing to keep in mind is that health conditions have changed since 2018. We've got the repeal of the Affordable Care Act's individual mandate going into effect in 2019, which would affect coverage rates. And then we've got in 2020, COVID-19 affecting availability through fewer non-COVID medical services. The affordability maybe it have been affected by lost income and lost insurance, and it has also affected willingness to receive care. And with that, thanks for attending and sitting here and listening to me tell you about this exciting report that Jessica and I put together. And I'm ready for any questions that people.
Thank you, Liz. That was really interesting. If you have questions, you feel free to put them in the chat or to unmute yourself and ask a question. And I guess I'll go ahead and ask the first question. Maybe I can get it started. So this is really interesting. I was just looking with Renee on some of the NCRCRD, NCR stat data that will be available to all of you very soon on looking at self-employment and insurance access and health. And one of the things that as we were looking at the tables is that, self-insured people, I believe, were less likely to think that they were healthy as wage workers. And so that was really interesting. And we were trying to see now whether if it's changes any by core or non-core. But anyway, let me get to the question. Sorry. So based on kind of like the non-core self-employment are less likely to have access, how do you think, telehealth and some of these new things that kind of COVID spurred a little bit more of, right? Because we couldn't, you might need to see your mental health care provider or something via telehealth. How do you think that will play, or do you think that that's a policy that we're going to have to look for more of those things as we look at like less doctors and things in non-core areas?
Well, so the standard is we can't speculate on policies, right? Because we have to give you the information, and policymakers need to take that information and do with it what you will. But I do say, I do think that telehealth does provide an excellent opportunity to potentially increase access to different types of healthcare. But that, of course, hinges a little bit on broadband availability or access, whether people have decent cell phone coverage so that they could even do like a full just voice type of thing. Those are the thoughts that come to mind right away. Jessica, did you want to add anything to that?
No, I think that's it, is that it's definitely an opportunity, and that internet or broadband access and technology is an important factor as a component there to delivering those services, because there are requirements, as I understand it, that providers have to make with having the correct applications that they can use and seeing video, which we know requires a stronger signal than non-video type care. But it's definitely an opportunity. As we've learned, COVID opened a lot of opportunities for a lot of new things that we don't quite yet have data on, or we're only starting to have data on.
Yeah, we do have, ERS does have a telehealth based report that was released in 2018 that uses 2015 data. So that data is pretty old now that you start thinking about the way that broadband has changed. But if you're interested in reading a little bit more about what USDA has done regarding telehealth, that might be a good resource to check out.
Hi, this is Shoshana Inwood. I'm at Ohio State. Can you hear me okay?
Yes.
Okay, great. It's really interesting presentation and thanks so much for sharing all this great research. And this is a little bit maybe more of an abstract question that I was just curious if you had thoughts or if there are studies that you would be maybe looking at further when thinking especially about the ideas about rural brain drain versus brain gain, and how maybe some of these factors of insurance might be playing into whether or not rural places are losing talent, or are they gaining, increasing population. Is just curious if there's any overlays that you've been looking at.
So this particular, we didn't intersect education with any of this for this particular research report. We were solely focused on what was going on for self-employed individuals. So unfortunately, I can't really speak to how that may be affecting it.
Okay, thanks. Yeah, because I think it's just this I think sometimes in community and economic development, we're struggling with, how do we really, healthcare is such an important part of workforce development, both and workforce attraction and then retention. And thinking about these things all together can be really complicated. So I was just also maybe curious if you had ideas about what kind of data sets could be put together to maybe help us understand a fuller picture of these dynamics.
Yeah. So I do know that another researcher in my branch, John Pender, has been working with some survey data that is looking at retention of healthcare workers in communities. It's kind of a dual. It's got some qualitative and some quantitative aspects to it. I can't say for sure when or if something will come out of that, but I do know that it has been something that we've been thinking about here. Yeah, I agree. It's definitely an important issue, that idea of brain drain and workforce retention and medical care. I mean, I wouldn't necessarily say that the type of coverage that you get is 100% going to be, my brain is not working now. I talked too long, can't think anymore. I wouldn't necessarily equate what we're finding here with things related to brain drain. I'd say that there's probably some relation between the type of insurance, and there may be, but I don't know. I can't say anything for sure.
Thanks so much.
More questions? Well, I guess I will, as maybe somebody will think of something as I'm talking. I will pull a plug that part of in our last newsletter for NCRCRD, we did have a data snapshot related to health perception in the North Central region. And so if you're interested in this topic, at least perceptions of health and all of these things, you can go to our website and see that kind of data snapshot. It's got the region and it also has it by state. And you'd be surprised some of the states that have households are rating themselves as healthier than others, and sometimes it's unexpected. And so that might be something that you might want to look at for your particular state and across the region. Was one last chance for questions? Well,
I guess I just have a comment, and I'm interested to see if anybody explores the dynamics with rural community development and the new options for remote work, and how that might change the populations in certain areas and the demand for health or the development of community resources, because I do think that a lot of what COVID's opened up is just a new way of thinking about where you live and how you work. And I think that there could be some opportunities for rural development as some people are moving into different areas and demanding more internet access and other kinds of services that weren't there before. And I look forward to seeing if there's data coming out on that. Looking forward.
Well, Jessica, I think that's really well put. And I think there are people very much interested in kind of remote work into rural areas and what is that going to mean, for workforce development, but also in any number of ways. So yeah, I know the South is kind of looking, when I say the South, and I mean the Southern Regional Rural Development Center, and us at the NCRCRD definitely think it's important. And it came out in some of the listening session in priority areas that we did nationally in terms of what Extension is thinking about in terms of rural, remote work, workforce development, health access. So yeah, there's definitely a lot of intersectionality on all of those topics. So if you're out there, you can start doing research on it or put in a proposal for a small grant for NCRCRD. Otherwise, well, thank you everybody for attending the presentation. Liz, Jessica, that was really great. A lot of great information. And remember, our next webinar is November 7th. Bye, everybody. Thank you.